In this video, I'm going to take a look at sympathomimetic pharmacology. A sympathomimetic drug is any chemical that either directly stimulates an adrenoceptor or promotes increased production of the body's own endogenous stress molecules, the catecholamines. In the realms of pharmacology, sympathomimetic compounds are more commonly referred to as adrenoceptor agonists. Breaking this down a bit, we can classify them based on either how they act, so whether they act directly or indirectly to stimulate adrenoceptors, or whether they act through a mixture of these two processes. We can also classify them by the type of adrenoceptor in which they bind to. An example of this could be the drug midodrine, which acts exclusively on alpha-1 adrenoceptors, or the bronchodilator salbutamol, that is selective for the beta-2 adrenoceptor. I'm going to work through the pharmacokinetics and pharmacodynamics of the more common drugs in this class and discuss their clinical relevance and the common adverse drug reactions. Let's start by going back a bit and think about how we can classify adrenoceptors. Adrenoceptors are subdivided into either alpha-1, alpha-2, beta-1, beta-2, or beta-3. Each of these are located in different tissues and produce different physiological effects when stimulated. Adrenoceptors are a family of G-protein coupled receptors that, when bound with a sympathomimetic molecule, produce a cascade of physiological events that allow the body to mount an effective stress response. Adrenoceptors use what we call a secondary messenger system. So if we take a look at the diagram, we've got our various different G-proteins that all sit on the cell surface, and these face inwards. Let's just draw that up. So we've got a G-protein here, G-protein here, and a G-protein here. When activated by the primary messenger, a sympathomimetic, these G-proteins respond by activating various intracellular enzymes, and this is what we call the secondary messenger. The sympathomimetic drugs directly exploit this, with the pharmacodynamics of these drugs actually being relatively simple. So we want to increase blood pressure, then what we could do is make a compound that works only on adrenoceptors. The pharmacodynamics of that drug would then be to bind to adrenoceptors and stimulate them in the same way as the body's own catecholamine molecules. So looking in terms of pharmacology, we can divide up any sympathomimetic or adrenoceptor agonist into one of three categories. We can say that they are either direct acting, binding to and stimulating a particular adrenoceptor, and most prescribed drugs typically fall into this category. They can also act indirectly, increasing the concentration of noradrenaline at neuroeffector junctions, which sit between sympathetic neurons and adjacent peripheral tissues. Finally, they can be mixed acting, having both of these properties but in varying amounts. Drugs can be alternatively classified as catecholamine or non-catecholamine based, or by whether they are specific or non-specific in the particular adrenoceptor in which they target. Let's now look at the alpha adrenoceptor in more detail and study the drugs that bind with them to stimulate their physiological responses. In terms of position, alpha adrenoceptors mainly exist on vascular smooth muscle in the periphery. However, they also sit on smooth muscle cells in many other tissues, such as the liver, skin, and urinary tract. To show where they are primarily situated, however, take a look at this quick sketch of an artery I've brought up here, and we'll look at how the binding of a sympathomimetic will lead to the desired physiological change being brought about. So for some background, we have three layers to our generic, large to medium-sized artery. The tunica intima, or innermost layer, the tunica externa, or outermost layer, and perhaps the most important layer in terms of the alpha adrenoceptor, the tunica media, which is the middle layer, consisting of smooth muscle cells, among other things. So here is our tunica media, in brown. Sitting on the surface of a smooth muscle cell within this layer is our alpha adrenoceptor. Attached to it, we can see the G protein that I mentioned earlier. And here you can see how it faces inwards, towards the cell, which allows the physiological effect to be propagated within the cell itself when it is stimulated by a sympathomimetic molecule. I think it's worth mentioning at this point that even though alpha adrenoceptors can be further subdivided into alpha 1 and alpha 2 adrenoceptors, it is really only the alpha 1 receptors that are of much importance in terms of the stress response, and so really what I've drawn up here is our alpha 1 adrenoceptor. The alpha 2 receptors are mainly classed as autoreceptors, being used in the negative feedback mechanism of noradrenaline. But for a conceptual understanding, I think it's fine to visualise the alpha adrenoceptor like this. So you've got the smooth muscle with the receptor sitting on the top of it and can be stimulated by a sympathomimetic molecule, which I've got in pink here. So if we take our catecholamine, which is this pink coloured molecule here, when it binds to the alpha adrenoceptors, it causes an artery to vasoconstrict due to all the smooth muscle tissue in the tunica media contracting at once. This then increases total peripheral resistance and subsequently leads to an increase in blood pressure. Let's look at an example of this to show some clinical relevance to using an alpha adrenoceptor drug. Let's look at phenylephrine. Phenylephrine is a common over-the-counter nasal decongestant and is classed as a selective alpha-1 adrenoceptor agonist. It is perhaps better known by its brand name, one of which is Sudafed, and is typically sold as an oral tablet or nasal inhaler. In terms of its pharmacodynamics, phenylephrine is a specific, non-catecholamine-based, competitive sympathomimetic. So what do I mean by all this? Well, the drug is designed to target only the alpha-1 adrenoceptor. It is non-catecholamine-based in its chemical structure, and acts competitively on the alpha-1 adrenoceptor to bring about its pharmacological effects. It is worth noting that the efficacy of any drug that is designed to be specific to a particular adrenoceptor is however greatly reduced at higher doses, and sometimes beta adrenoceptors can be stimulated inadvertently when using an alpha adrenoceptor, and the opposite is true for a drug which selects for beta adrenoceptors. But I will come on to that in a moment. The binding of phenylephrine to an alpha adrenoceptor on the smooth muscle in the nose tends to produce vasoconstriction, reducing the vascular congestion and opening the nasal passages to facilitate normal breathing. This is what makes this drug so good when you have the common cold, reducing all that nasal congestion that makes it so hard to breathe. The drug's effects are achieved by promoting the secondary messenger system that I talked about earlier, leading to an increase in intracellular calcium levels that causes smooth muscle contraction in the tunica media. So that's really it for its mode of action. In terms of its pharmacokinetics, however, this is a bit more interesting. Phenylephrine has a good systemic absorption through any administration route, but it has a pretty poor ability to be passed around where it needs to go due to its 38% bioavailability, which mainly results from being broken down extensively by the liver enzymes during its first pass metabolism. This is the main reason why phenylephrine tends to be prepared as a nasal inhalation, allowing the greatest concentration of the drug to be in the area where it's going to be needed most, and therefore reduce the unnecessary side effects resulting in the stimulation of adrenoceptors in other tissues. That's if it was even able to get there in the first place, as its bioavailability is pretty poor. Okay, so the second class of receptor in the sympathetic nervous system are the beta adrenoceptors. And in contrast to the alpha adrenoceptors, these are located basically everywhere else. The beta adrenoceptors are divided up into three main types, beta 1, beta 2 and beta 3, but it's the first two that are really of any importance in terms of any pharmacology of this system, with the beta 3 receptors' function being somewhat uncertain when looking at the literature. Beta 1 receptors are located mainly on the heart and on the kidney. Beta 2 receptors are situated mainly in the airway. However, this is a bit of an oversimplification, and it is worth noting that they also exist in various other body tissues, such as the brain, kidney, pancreas and GI tract, with even some situated on skeletal muscle. Therefore, it's good to have in mind that beta receptors have a variety of effects in addition to the ones I'm going to mention here. To show the distribution of these receptors in the body, let me bring up a simple diagram of the heart and lungs. Beta 1 adrenoceptors essentially sit on the electrical system of the heart, with receptor sites on the sinoatrial node, the natural pacemaker, the atrioventricular node, the conducting node, as well as sitting on the surface of contractile myocytes, sitting on the heart muscle itself. In contrast, the primary sites of the beta 2 adrenoceptor are in the lungs, where they sit on bronchial smooth muscle. Stimulation of the beta adrenoceptor, which, to reiterate, can be done by any molecule that shares a common chemical structure with adrenaline, will lead to a variety of physiological effects that underpin the stress response. The beta-1 receptors all tend to increase cardiac output when stimulated, and therefore raise blood pressure. The beta-2 receptors all tend to cause smooth muscle relaxation, and in some cases counteract the changes brought about by the beta-1 receptors altogether. Let's now look at a couple of drugs that target the beta adrenoceptor specifically, to get an idea of the clinical disorders that can be managed with beta adrenergic agonists. An example of a beta-1 specific agonist is Dobutamine. This is a synthetic catecholamine drug used in the treatment of heart failure. In terms of its pharmacodynamics, Dobutamine binds specifically to beta-1 adrenoceptors in all three areas of the heart I've highlighted in the sketch before. We can say that Dobutamine causes a positive dromotropic and a positive chromotropic effect, increasing the initiation and speed of the heartbeat by binding with the receptors in the sinoatrial and atrioventricular nodes. This therefore tends to increase heart rate and raise cardiac output. It also has a positive ionotropic effect, increasing stroke volume but through stimulation of receptors in the muscle cells of the myocardium itself. Let's move on now to another drug, Salbutamol, a drug which is used in the treatment of asthma. In terms of its pharmacodynamics, it is classed as a selective beta-2 adrenoceptor agonist, tending to bind to receptors located in bronchial smooth muscles particularly, and leading to a relaxation of smooth muscle tissue through the activation of the secondary messenger system. You may recognise salbutamol if I tell you that it is commonly marketed as Ventolin. This sometimes can be seen as the blue inhaler that is carried around by asthmatics as their reliever inhaler and used for the treatment of bronchospasm. In terms of pharmacokinetics, salbutamol can be administered either orally, parenterally, or by inhalation. Inhalation is usually favoured, however, in order to reduce the adverse drug responses caused by stimulation of other adrenoceptors, as at high doses its selectivity reduces greatly. Another reason this is done is because of the low oral bioavailability, as a result of the drug's incomplete absorption from the GI tract if it was delivered orally, and due to extensive first-pass hepatic metabolism. Using the inhalation route allows most of this first-pass metabolism to be avoided, as the drug is administered directly to the area in which it's needed, just as was the case with phenylephrine. The main adverse reactions of this drug are related to overstimulation of the sympathetic nervous system. Tachycardia, nervousness, and muscle tremors are all possible through indirect stimulation of beta and alpha receptors in the heart, CNS, and skeletal muscle. Let's now look at a couple of drugs that are non-specific in the receptors that they stimulate. I want to go through a common catecholamine-based drug, and then look at indirect acting agents that don't even bind to adrenoceptors directly, as was the case with the other drugs I've looked at in this video. Catecholamine-based drugs are mostly used in the treatment of various types of shock, examples of which include cardiac arrest and anaphylaxis. They can, however, also be added to local anaesthetics for use in dental surgery, for example, to promote vasoconstriction of the small arteries in the mouth and allow maintenance of a clear surgical field. As these are non-specific drugs, they bind to all the different types of adrenoceptor in varying amounts, which is mainly dependent on the dose and size of the catecholamine molecule administered. As a result, they tend to be used only in cardiovascular emergencies, or sometimes in heart failure, as if a particular physiological response is needed, the prescription of a more specific drug is usually indicated. A good example of this is adrenaline, but the type that is synthetically produced and is available in intravenous or intramuscular injections, such as the EpiPen, or combined with a local anaesthetic, such as bupivacaine. Lastly, and really for completeness, I want to mention the indirect acting sympathomimetic drugs. The pharmacology of these drugs is a bit more involved and is really outside the scope of this video, but I think it's good to have an overview nonetheless. The best examples of these are methamphetamine and ephedrine. You may recognise methamphetamine more by its slang names, such as meth or speed. This type of sympathomimetic acts by increasing the concentration of noradrenaline at the synapses of sympathetic neurons by stimulation of alpha-2 adrenoceptors in a bunch of different tissues. These drugs are used for a diverse range of conditions, from ADHD to narcolepsy to obesity, as well as being used as the illegal CNS stimulants that we hear the most being used for. They also behave as potent sympathomimetics, and therefore can produce all the same stress responses as adrenaline, but usually in a much stronger way. This really makes it perfect as a recreational drug, as you wouldn't need to inject it to get CNS stimulation every time, like you would have to for adrenaline to get the same effects. This raises an interesting question. We could argue that, if the more potent sympathomimetics, such as methamphetamine, produce the same effects as weaker drugs, are better at doing their job, and can save time and medical resources by being able to be administered orally, then why don't we just use methamphetamine instead of adrenaline for a treatment of anaphylaxis? Or why don't we use ephedrine rather than phenylephrine for nasal decongestion? I encourage you to pause the video here and have a think about why this isn't the case. So I'm assuming you paused the video and had a little think about this. Well, really this is because of two things. For one, the non-specificity of the agents such as methamphetamine leads to a high side effect profile, and this is because of all the adrenoceptors in the body being stimulated, and therefore along with increased alertness would come a migraine headache, rhabdomyolysis, and a reflex tachycardia. The second reason is that due to the potency, there is a high likelihood of physiological dependence with repeated administration of a drug that is non-specific, and therefore possesses a high degree of CNS stimulation. It wouldn't be an acceptable side effect for an individual with anaphylaxis having to endure a depressive episode of their coming off a drug, when an alternative with more specificity for the physiological effects that they're experiencing exists. So to review, sympathomimetic drugs include Alfred Receptor agonists that mainly stimulate receptors on smooth muscle tissue of peripheral arteries, and produce vasoconstriction. They also include beta receptor agonists that tend to stimulate receptors on heart and lung tissue and lead to increased cardiac output and bronchodilation. Sympathomimetic drugs are used to treat a variety of pathologies. Alpha receptor agonists can be used as nasal decongestions, where beta receptor agonists are used in the treatment of asthma and heart failure. Non-specific or mixed receptor agonists, such as adrenaline, are used in the treatment of cardiovascular emergencies, such as cardiac arrest and anaphylaxis. Recreational drugs, such as methamphetamine, also have sympathomimetic properties through complex interactions with the sympathetic nervous system. In the next video, I'm going to take a look at the opposite class of drugs, the sympatholytics, and start off looking at the topic of antihypertensive pharmacology.